Hello, everyone. Welcome to the Preemie Health Talks. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation, and your host for this event. The Preemie Health Talks is the first of two international live series that CPBF is hosting 2020 in recognition of World Prematurity Day. Next month, we will have the Preemie Power Week, and all the information is available on our website. These educational sessions are in collaboration with the International Family Integrated Care Committee, the Canadian Association of Neonatal Nurses, EFCNI and Glance, the Global Alliance for the Newborn Care. For those not familiar with CPBF, we are a charitable organization, and our mission is to support and educate Canadian families of premature babies every step of the way. We believe that through consistent information, access to helpful resources, and peer support inside and outside the NICU, we can empower families, ensuring they are ready to take care for their baby. Consistent information is especially important today when we are facing a global pandemic. With the Preemie Health Talks and the Preemie Power Week, we intend to bring you the guidance of healthcare professionals and the knowledge gathered by researchers around the world, which are extremely valuable to help us care for families and their babies. I want to thank AbbVie for the unrestricted educational grant, Pampers, and our amazing team who worked really hard to organize this event. And today we have here Dr. Paula Meier talking about breastfeeding, RSV, and other viral illnesses. Respiratory Syncytial Virus, RSV, is common among the general population, but can result in more severe symptoms in premature babies, especially those born very low birth weight. This presentation highlights the evidence for mother's own milk feedings as an effective strategy to reduce the severity of RSV and other viral illnesses in premature infants. Dr. Paula Meier is PhD, a registered nurse, and a professor of pediatrics and nursing at Rush University Medical Center in Chicago. Dr. Meier has worked as a practitioner, researcher, and educator in the area of human milk, lactation, and breastfeeding for premature infants and their mothers since 1975. She currently leads the multidisciplinary Rush University NICU Human Milk Research Team that has conducted numerous externally funded translational research and demonstration projects focused on the removal of barriers to high-dose, long-exposure mother's own milk feeding for NICU infants. You can read her full bio in our website. Dr. Meier, thank you so much for joining us here today from Chicago. What an honor to have you here. I've been following your work for a few years, and I'm so grateful that you're joining us here now.
Thank you. There's absolutely no group that I enjoy speaking with more than families of NICU babies. So it's truly a pleasure to have been invited. And I'm going to now share my screen. Like everyone with technology, this will just take a second to get it into presentation mode and get me completely ready here. So breastfeeding and protection from RSV and other viruses. I've chosen to highlight the evidence in this area, as well as providing some practical strategies so that families are empowered with the information that they need to make the right choices for their babies and for themselves. I always start with disclosures so that people can see the types of research funding that we have, as well as philanthropic funding and demonstration funding. I've put the Family Larson Rosenquist Foundation funding in yellow so that it's highlighted, because several of the actual parent information sheets that I'm going to be sharing as a part of this presentation were actually funded with a grant from this foundation that was focused primarily on taking what we know about all the evidence of mother's own milk for babies in the NICU and putting it into videos and education sheets so that it basically takes the science to the families. And I'm especially proud of this compendium because it pushes the boundaries of what we can expect families to understand and know. So I encourage this group especially to check the website for this foundation. I have it later in the slides, so that you'll be able to actually see these materials. There are 25 educational sheets and a number of short topic and long topic videos that are geared towards educating families about pumping, about feeding their babies at breast, about the outcomes of mother's own milk feeding. So I encourage all of you to know this is available and to look at the website. So moving into RSV. So what we know about RSV, if we were to take it and say just very simply one takeaway message, is that nearly all published studies, in fact, there's only one that did not find an effect, nearly all published studies support the studies. They range from epidemiologic studies, which basically look at huge populations, case control studies, and those primarily are comparing what were the risk factors in babies that developed respiratory syncytial virus and babies who did not. So it's basically comparing cases with controls. And then actual case studies. And the case studies, and I'm going to show several of those, actually focused on following babies with RSV for periods of time to determine the impact of mother's own milk. There's also been a number of studies, and I've not gone into great detail with those, but I've highlighted them so you can see them. There are studies that actually have looked at composition of the milk to determine what is providing the protection that we see with RSV. Now, no presentation of this type would be complete without understanding that this is a line of work that really has a lot of limits to the studies that inform us. First of all, even diagnosing RSV is inconsistent because many of the studies assume that RSV is the problem or refer to RSV and other viruses when babies come in with a primary diagnosis of bronchiolitis or lower respiratory tract infections, especially in the first 2 years of life. So it's assumed many times that this is RSV. I don't need to tell this group likely that how breastfeeding is measured is very inconsistent. Some of the studies focus on whether babies had ever had an exposure to breast milk. So this might have been one feeding, and it might have included babies that had only one feeding, all the way up through babies that were exclusively breastfed. One of the biggest limitations, and I'm going to come back to this over and over, is that we really don't have a good sense of what is protecting. Is there a role for protection in babies who have been breastfed, or is that protection only for babies who are currently breastfeeding? Most of the studies tease that out, but not all do. And the mechanisms of protection are really very different. So I'm going to talk about those as we go through. We also know that although the group of babies that's most likely to have the greatest risk for RSV, especially with severity of RSV, are our extremely premature babies. And for the most part, we have scant data on that population other than to know they are at risk. We don't have good data with breast milk with that population. We also know that many of the studies don't control other risk factors. So for example, household size, smoking parent, those are things that the good studies should control, and some do and some don't. And then I will come to this last I guess I would call it a limitation of studies, in that when we look at, does breast milk protect babies from the incidence of this problem, or is it the severity? And when we look at severity of illness is really something that is hard to measure. People look at severity of illness as to whether a baby was admitted to the hospital or whether the baby went to seek, or parents took the baby to seek care. The duration of the hospital admission, the amount of respiratory support required, and all of those things are really dependent many times on parent factors, on hospital factors that are really not necessarily strictly based on the severity of illness. So with that background, I thought I would highlight my presentation with the fact that we first learned about the protection of breast milk and breastfeeding with RSV in studies of the ferret and the cotton rat, because it was with these two groups of animals that that we began to see this protection when the mothers were immune with these viruses. And then the next thing I want to go into is when we talk about protection from RSV, we can talk about protection both in terms of, is your baby less likely to get RSV? Or if your baby gets RSV, is your baby less likely to have severe symptoms? And this is really an issue that's important because we don't have good data on the incidence of RSV. To do that, we would have to have an entire set of data on the population of babies who became infected and did not come infected. And usually we only see the babies that have symptomatology for RSV. So when we look at the data, protection has really, all the studies have focused primarily on if a baby acquires RSV, is the baby likely to have less severe symptoms? So that's what we call protection from the severity of the illness. And a lot of the mother's milk studies, and it really show protection from severity as opposed to illness. And I've got several slides as we go on that highlight that idea. But what I want the parents to think about is that breast milk likely protects both from the incidence and the severity, but probably the greater degree of protection is from the severity versus the prevalence. So if we start with some of the historical work in this field. So there was a large RSV outbreak in the United Kingdom in 1973 and 1974. And this publication focused on a case control trial. And what that means is the researchers compared the babies that had RSV, and in this case, again, 116 babies that were admitted to the hospital, and compared those babies with 167 controls that were not admitted to the hospital during that season. And what they found was that of the babies that were breastfed versus the babies that were controls, that 8 of the 116 RSV babies were breastfed versus 46 of the 167 controls. So what that means is that the babies that were breastfed were significantly likely to be positive for RSV. So that shows, again, an issue that was with incidence versus severity. Now, of the babies that were breastfed, what was really interesting in this study was that of those babies that were breastfed, over half had received mother's own milk for a very short period of time, but that short duration provided protection over those that were never breastfed at all. And this was one of the few studies, even back at this period of time, where breastfeeding was still significant, even when controlling in the data for the effect of social class. Now, this was one of the first studies that proposed that what was really going to be protective from RSV in the absence of continued breastfeeding. So again, these babies, for the most part, over half received very short exposure to breast milk, but they still were less likely to be RSV positive. So there was a separate study within this study that actually analyzed colostrum samples. And all of those samples had neutralizing activity to RSV. So what is really interesting is that this was one of the first studies that teased out colostrum. And it's the early introduction to colostrum that may provide long-term protection from RSV. So the early studies, again, began to follow a reduction in RSV hospital admission. So we're moving now into some of the incidence and the severity studies. So what these studies showed was that breast milk composition, again, showed RSV neutralizing ability. In other words, the milk itself could neutralize the impact or or attenuate the impact of RSV immediately after birth in colostrum, as well as up to milk that was 7 weeks into lactation. So these studies, again, all showed a reduction in RSV hospital admission. But again, keep in mind, if you didn't present with some type of an illness, that we don't know what the actual prevalence or the incidence of RSV was in the general population. So these are moving more into severity. And then if we move into some of the risk factors and looking at did breastfeeding emerge as a reduction in risk? There have been several big cohorts where RSV has been studied. And this is actually one of the papers that's a comprehensive review, if anyone would like to look at it. So there were several different cohorts of babies that had been followed that were reviewed in this study and found that in the different cohorts, so one is the flip, one is the risk, and one is the risk 2. So each one of those individual studies in this review of what are the risk factors that reduce the severity and the prevalence of RSV, each one of those single cohort studies found that babies that did not breastfeed at least 2 months increased the risk of RSV. And if you look at especially the FLIP study, it was over 3 times. So again, the thinking is that there is a protective effect of babies having been breastfed on RSV. What we don't know, and I guess I will come back to this here for a second. What we don't know, again, is a lot of the data about exposure for premature babies. This study was with premature babies, but again, going into the VLBW population and the extremely preterm infants and mother's milk receipt, we really don't have the good detailed information that really should be done at this point in time. So this paper looked at bronchiolitis and found, and I'm going to show you here the probability of hospitalization. So again, what we're getting into here is the severity. If your baby comes down with RSV, is your baby likely to be admitted to the hospital because of symptomatology? So again, this was bronchiolitis, and the assumption on the part of the researchers was that most of the bronchiolitis in the first year of life is related to RSV, or at the very least other viruses. So looking at breastfeeding, the red are the babies who have never been breastfed. Okay, so we can see that all the way across that first year of life, so going from newborn all the way through to 12 months, that the risk of being hospitalized if your baby was never breastfed is significantly higher than if your baby was breastfed. So then the researchers looked at ever breastfed. So this green is the babies that were hospitalized who were ever breastfed. And you can see significantly lower probability of being admitted to the hospital with ever breastfeeding. Then the researchers looked during the first 6 months when the recommendations are for babies to be exclusively breastfed, looked at babies that were exclusively breastfed or had some mother's own milk and formula. And I think this is what's interesting to take away, because what these researchers showed was that it didn't matter if the babies were exclusively breastfed, that even mixing breast milk with formula, not in the same milk, but I mean mothers that were doing both, there was still that protection afforded the baby over that first 6 months of life. So I think these are really things that make common sense decisions. You know, I often will say in my own practice with mothers, for years I've always said, one of the most important things to do, even if you have to go back to work, even if you don't want to breastfeed long term, if you don't want to pump at work, one of the most important things over flu season, and this was before COVID and before even, and not just exclusive to RSV, the most important things is if your baby can get even 1 or 2 feedings of your milk each day. So whether that means you breastfeed your baby before you go to work and when you come home, or whether you pump your milk before you go to work and when you come home, even if your baby gets some milk, it's going to help lower the risk of your baby with respect to any viruses over this time. So I always, for years, this has been a message to families as they get ready to take premature babies home from the hospital. It doesn't have to be an all or nothing. So just because you don't think you can provide your baby exclusive milk, don't stop entirely. And that would be a takeaway from this graph. So then if we look, this was again a larger study that I want to just, so you're aware of having been done, that breastfeeding reduces the severity of RSV infection among young infants. So this was a multi-center study of 203 infants that were tested positive for RSV and were followed for 10 days. So this would almost be like a case study if we were talking about the different types of research into this field. So the babies were followed really closely. The breastfeeding categories were babies that were fully breastfed, which was 43% of the babies, partially was 35%, and token or none was almost a fourth of the population. Among the breastfeeding babies, or among the babies, there were no differences with respect to age, sex, or birth weight as to whether they were getting breastfed. So these researchers measured severity indices over this 10 days after babies were diagnosed with RSV. And this is the data, these are the data. So what they looked at, did the babies require hospital admission? So let's go to that one right up here. Did the babies require hospital admission? So as we can see, even though we would look at the babies that were fully, partially, and token, it looks like the babies that were fully breastfed were less likely to be hospitalized, but the statistics show that that's not the case because this was not statistically significant. So whether or not the baby was admitted to the hospital was not a good measure or was not associated with exclusive breastfeeding. However, when the researchers looked at whether the babies required oxygen therapy when they were admitted to the hospital, the babies who were fully breastfed were significantly less likely than the partially breastfed babies, and those were significantly less likely than the token breastfeeding babies to require oxygen. So this is basically what we would call a dose response. The higher the dose of breastfeeding, the less likely the babies would need oxygen. And then the same thing was found with duration of hospitalization, which was statistically significant. The babies who were fully breastfed were in the hospital a shorter period of time than the partial, and they were in a hospital shorter period of time than the token. So again, what those show is a dose-dependent effect, meaning the higher the dose of milk the baby received, the shorter the duration of the hospitalization. So these were some of the early measures of severity of infection. So now as we've, I think, shown clearly that we absolutely reduce the severity of the infection. Do we reduce the risk of getting the infection? The data are less compelling, but the few data that we have show that there is protection. But again, that's something that's a limitation that's really hard to measure because we don't have a good idea of the babies that present to the hospital, how many of those babies are represented from the population of babies that might have RSV that don't get into the study. So the data really suggests that there's a strong effect of severity. Now, if I were to look at these, and what I want to share with you is the data show that there is an effect of previous breastfeeding as well as active breastfeeding. And I want to kind of go through what the mechanisms are. I've got some complicated slides, but I'm not going to go a lot through the slides. I'm just going to explain what they mean. What this means is that if you have previously breastfed or provided milk for your baby in the NICU, there are mechanisms that are going to reduce the severity of the infection in your baby. If you were breastfeeding at the time of the hospitalization and are still breastfeeding at the time your baby develops RSV, chances are that this is going to be additive to the previous breastfeeding protection. And that's what I want to go through. So some breastfeeding in the past is very helpful, but it's probably even more protective if you are actively breastfeeding at the time your baby is exposed, which again comes back to my whole recommendation to mothers about if you can manage to keep this up over the the flu season or the viral season, even a couple of times a day. That's beneficial. So I'm not going to go through this paper because I think it's quite complicated for what it is supposed to say. But basically, one of the main mechanisms of protection, if we look back to this whole idea of getting a little bit of milk, even in the first month or two, still being protective after that period of time, really comes into the way that human milk works in protecting babies right now from all types of complications, full-term babies and premature babies. And that is the focus, that the milk doesn't just provide protection while the baby is receiving it, but mother's own milk is truly a way that of programming, and by that I mean putting in place changes that stay with the baby over the lifespan. And one of those is immunomodulation. And what that means is you don't just protect your baby from infection while your baby is getting your milk, but that your milk basically educates your baby's own immune system to take care of itself later on. And what that means is that it sets in place a whole array of programming of these different ways that your baby's going to fight infection certainly over infancy and over childhood, but over the years to come as well, as far as what the data show. So this paper basically elicits and describes each one of the components in milk that are responsible for this immunomodulation, or in other words, putting in place with early breastfeeding a way of protecting your baby against illnesses over the lifespan. One of the other ways that your milk does this is that we've known now for probably 15 years with good data that mother's own milk contains an array of protective bacteria that are shed to the baby during breastfeeding, or if you're a baby mom who's pumped for your baby, your pumped milk does the same thing. These bacteria are good bacteria, and what they do is they interact with your baby's immature intestine and help develop your baby's intestine so that it develops healthy and in a way that matures it so that it's able to tolerate food better. So this is a consequence in large part of the bacteria that come from your milk, along with the special sugars in your milk that are food for those good bacteria. Those are called oligosaccharides. Well, we've known for a long time that the first intake of breast milk is a way of shaping the baby's intestinal bacteria over this period of time, especially through to weaning. So over that first 6 months of life, adding layer upon layer upon layer of your breast milk with its unique bacteria provides your baby with the best protection from, for example, in the Nicu, from necrotizing enterocolitis, from infection. There's even relationship between the mother's own milk bacteria and neurodevelopment in babies. But where I want to go with that is that the data from this paper are the first that ever showed a dose response between the type of bacteria that come from the mother's own milk as well as the maternal nipple surface, and isolating them from the infant's intestinal tract as the good bacteria that live there even long after the mother stops breastfeeding or providing her milk and solid foods are introduced. So what your milk has in the way of good bacteria for your baby help reduce the likelihood of any type of infection, as well as many other complications of prematurity. And again, that's dose response. The more of the milk your baby gets, especially in this first 30 days of life, really help to shape a healthy intestine for your baby. But this is what I wanted to get to as well. And this is a brand new paper that just came out that basically shows that breastfeeding not only shapes your baby's microbiome in terms of the bacteria, but because of those bacteria, this stepwise process also shapes your baby's response to viruses. And many of the viruses that would ordinarily evolve and become concerning in a newborn baby as we go from, as you can see in this graphic, from month 1 to month 4, many of those viruses are inhibited by breastfeeding. So this, I think, is something that's brand new. So it's not just your milk providing good protection from bacteria that would harm your baby, but from viruses as well. And then I also want parents to understand that this is a study that's not a new one, but we've had it for a long time, is that when, and this would get more to the act of breastfeeding at the time your baby becomes sick. So let's say, for example, you're in a household with other young children, and the other young children develop this virus, and your premature baby comes down with it as well, and you're breastfeeding. What this study shows is that the simple infant illness, when the baby is actually nursing, actively infected, changes the immune composition of your milk that you're providing your baby in real time. So in other words, your baby, by having RSV, is going to let your body know this, and your body is going to make specific reaction, or I don't want to say antibody because it isn't just antibody. A lot of this protection is in the actual cells that your milk has. So your milk is going to have special protection for the specific viruses or infection in your baby. And it changes as a consequence of your baby being ill. Well, we say, well, how can this happen? Well, this happens because when your baby is breastfeeding, when your baby is feeding at the breast, your baby basically puts all of the bacteria and viruses into your milk, into your breast tissue, largely through this backflow of milk after breastfeeding. So if your baby's breastfeeding and breastfeeding's over, all of those organisms from your baby will go back into your breast. That actually works so that your body interprets these as an antigen or a germ, if you will, that it needs to make protection for you. So while you're actively breastfeeding, we can actually go into the next slide. So while you're actively breastfeeding, your baby will put those germs onto your body, either through the breast milk, like I just said. If you kiss your baby, through the kissing, through the touching, all of those things send those germs into an area of your intestine. And your intestine is going to make antibody as well as organize different cells to protect your baby from this. And those actually home to your mammary gland and into the breast milk for your baby. So that's when I say the best way to protect your baby from the severity of RSV is to still be breastfeeding at the time your baby is exposed. Before I move on from here, and I'm almost finished, I want to give one more idea here for parents. Just so you know, because let's say, for example, you come down with the RSV, and you probably aren't going to have the symptomatology, or your baby, it would be like a flu-like or a cold symptom. It would be the same recommendation for mothers who come down with COVID and they're breastfeeding their babies. You should not stop breastfeeding your baby, because you are still going, if you have been around your baby before either of you develop symptoms, you've already shed the virus to your baby. But what you want to keep in mind is that in real time, your body is making antibody as well as other anti-infective components that are going to protect your baby from the severity of this disease. So whatever virus that is, this is called the intramammary pathway. You don't want to stop breastfeeding. In fact, that's probably the worst thing you can do, because you're giving your baby the medication to help fight the symptoms of this disease, in addition to just breastfeeding. One final area that I want you to be aware of, and I'm going to kind of go through this quickly, is that I've talked to you about how the bacteria in your milk help to shape healthy environment that's hostile to germs in your baby's intestine. The studies are that this same thing happens in your baby's nasal and oral pharynx, in other words, the nose and the throat. And what we know is that when mothers are breastfeeding their babies, or this would even be if you've decided you're feeding your baby your pumped milk through the bottle, what we know is that there is a special protection that is built up in your baby's mouth as a result of breastfeeding or receiving your milk. And what that means is that goes into protecting your baby from the ear infections. In fact, that's thought to be one of the main mechanisms to protecting from ear infections, as well as upper and lower respiratory disease, which would be the bronchiolitis. But what most people don't know is that there is even a better reaction than what would just be in your milk. So if we were to study your milk alone and look at what it does with bacteria, it's nothing compared to what happens when we mix your milk with your baby's saliva and then expose it to the different germs. So anyway, what we see is that there's this powerful interaction that basically inhibits the growth of germs in your baby's mouth and throat. So this is one of the education sheets that was funded from the Family Larson Rosenquist Foundation. And this is the way that your milk is going to work to help protect your baby. And I developed this for using mother's own milk as oral pharyngeal or mouth care in the NICU, but the principle is the same with the RSV protection. Is that first of all, your milk is absorbed by your baby's tonsils and adenoids and goes throughout the body to provide protection from infection. There are special sugars in your milk that work to basically coat or paint the inside of your baby's mouth, making it difficult for germs to stick to them and get on. Your milk has special bacteria, and that's shown here with the blue shield that's showing that these are the special bacteria that protect your baby from germs, and the green being the germs. Some of the bacteria or the germs actually receive parts of the milk sticking to them, so they can't get inside to your baby's mouth tissue. And then finally, we see the combination of your baby's saliva and your milk that's extraordinarily protective. So this is actually in one of the education sheets from the Family Larson Rosenquist Foundation that I developed, which is mouth care with mother's own milk for your NICU baby. So it's focused primarily in NICU. And we also, just kind of as a caveat, in the NICU, there are several studies that show that the use of mother's own milk, oral pharyngeal or as mouth care, reduces a number of different complications, and the most recent one being ventilator-associated pneumonias because of this unique way of the milk interacting with your baby's mouth. But that is, again, a way of reducing what we would call the bronchiolitis or the upper respiratory infections. I want to leave you with one final thought, which I think is often misconstrued, and that is that pasteurized donor human milk does not provide this protection. It's only your milk. And there are several papers that show, and one of them that you see here is one that I authored, that really highlight the differences in mother's own milk and donor human milk. But I want everybody to understand that just because your baby had high doses of donor milk, or you weren't encouraged, or you think, oh, well, it's just easier, I'm not going to promote mother's own milk, I don't want to make mothers feel pressured, that the evidence isn't the same, because the donor milk does not provide that protection. So I talked a lot about how milk works to shape and develop different systems within the body, one being the ability for your baby to fight infections. I just want to highlight once again this education sheet from Family Larson Rosenquist. It's Why Does My Milk Matter for My Premature Baby? Again, what I've tried to do with these, and it's actually even evoked some criticism from time to time among people, is I've tried to empower parents with information with these that really pushes the envelope between what people think parents should know. So I hope that you'll all seek these out and try to use them as your own empowerment for what you know is important for your baby. And then the final one I wanted to share with you is Why Does My Baby Need Donor Human Milk? Which again talks a little bit about the limitations of donor milk compared to mother's own milk with a number of different outcomes. So in summary, I have made it a practice forever to explain to parents that any breastfeeding for even a short duration appears to reduce the inflammatory response to RSV. And there's some data that colostrum is the most powerful way of doing this. But that active breastfeeding during the RSV season is probably one of the primary mechanisms within your control for reducing the severity of illness, especially if you are a family, which I know most of you are, where you have an at-risk baby, a premature or a baby with other illnesses or problems that would compromise immune response. And especially history of allergy and safety, because allergy, asthma seem to also be another risk factor for RSV. And breast milk and breastfeeding actually reduces the risk of both of those. So thank you. I hope that this will be helpful for you, and I am happy to take questions if there are some questions.
Thank you, Dr. Meier. That was incredible. You can stop sharing your screen so you can see you in a bigger size on the screen. That's wonderful. So much information. So like very important information for families, but also for healthcare professionals who work with our families. I think it's never too much to reinforce the importance of breast milk. And I think the message is very clear that breast milk is so very important for babies. So my first question to you is, oropharyngeal care, how early can we start that? Because now we have babies born at 22, 23 weeks who might need mechanical ventilation right away. Can they start on that therapy or that care right away?
So that's a really good question, because again, it relates to some of the educational materials we've made for families about this. So the evidence is that the earlier you can start it, the more beneficial it is. So as soon as there's a drop of colostrum available, it should go right into the baby's mouth, regardless. And this actually began, this whole work with oropharyngeal care began with one of my PhD students back in the 1990s. And her work at that time was babies under 1,000 grams and babies that were intubated. So this technique actually began as a way to introduce mother's own milk to babies before they were stable enough to receive it as a feeding. So, so the earlier you have, the only thing limiting when you start it is whether you have colostrum. So that's why I think, again, that focus on having mothers and families understand, the sooner you can start to pump, the sooner you get a drop or two of colostrum. This is, you want to insist that it goes for your baby for the oropharyngeal care. It can be diluted with a little bit of sterile water so that there's enough of it to go into your baby's mouth. And typically the recommendation is somewhere between 4 to 6 hours, each 4 to 6 hours. And if it's a really small baby, you'll want to do it in and around the time that your baby is having feedings or some type of hands-on care, so you don't interrupt the baby's sleep. But no baby is too small. In fact, the smaller the baby, the greater the benefits likely. But there is, along with this education with Family Larson Rosenquist, we created, I believe it's about 6-minute video that's called Mouth Care for Your NICU Baby, that shows how to do it. And it shows because ideally this should be done by the parents, shows the parents doing the oropharyngeal care, and describes what I talked about, the mechanisms, how the milk works to provide this protection.
Okay, so we have a question coming from our live audience. Can you talk more about the benefits of exclusively pumping milk? I try to find research on it and often only come across that breastfeeding is better. There is limited information on exclusively pumping.
Okay, so exclusively pumping instead of feeding at the breast, I think is what we're saying. Okay. Okay, well, you know, I should probably start by saying in our population of mothers, when I first began the work I did in a large urban medical center in the 1995, I was met with a group of mothers that were perfectly willing to pump, but did not want to feed their babies at breast. And I learned from those mothers basically by understanding that sometimes it was just that they'd never really even thought about it. So I would just caution, one thing I would have you think about as a mother with a baby in the NICU, is I always want the mothers to try in the NICU. And if they decide they don't ever want to do it again, then that's it. But I've had too many mothers that realize, okay, it doesn't hurt, my baby enjoys it. So then they do want to go on and breastfeed. But my focus is you never push. If a mother's decided to pump, that's what we're going to do. So I would say the only difference that I can see likely, for example, if we were talking about RSV and pumping, is that the absence of the baby at the breast, you're probably not going to get quite the same inoculation, the baby putting the germs into the mother's body specifically through the breast. So you probably won't get that response, but at the same time, your baby would put those same germs in your mouth, your skin, so you would still make them in your milk. So I think that a mother who chooses to exclusively pump versus a mother who breastfeeds, your baby would be getting all of those same benefits. I don't think we have anything to say that your baby wouldn't. And there's no question that that's better than formula. There's no question it's better than donor milk. And I would have the confidence to say, it's my choice to feed with the bottle, it's my milk. And because I know that there's so much pressure about that not being the right way or not being the natural way, it's your way and it's what you're comfortable with. And your baby is getting a tremendous benefit. I've had mothers that have exclusively pumped for 14 months.
So I actually pumped for almost a year. My son could only come to the breast after 40 weeks in the ICU because he was ventilated for very long, and then he was on CPAP. So we use a lot of the frozen milk. Do they have the same benefits? Because I understand what you said about the passing the germs and the virus and the bacteria for the mom's breast, but if you freeze the pumping milk, the child still benefits as much as the fresh milk.
So I think, again, what you want to think of always is the perfect being the enemy of the good. So if your choice is you're going to feed frozen breast milk versus formula, there is absolutely no question it's better. Now, what I will often have mothers do is if you have, let's say, and your reason for feeding the frozen breast milk. So what is not in your frozen breast milk is the benefit of the intramammary pathway at the time your baby is ill, okay? So what I will often have mothers do, instead of going, if they want to wean, or if they want to stop pumping their milk so much, or they want to move from exclusive breastfeeding into some partial breastfeeding, is to try to do that more gradually so that they use some of the frozen milk and the baby still gets some of the fresh milk. So if you're breastfeeding or pumping fresh milk for your baby 2 or 3 times a day versus all the time, and then you go to all fresh milk to pumped milk, there's nothing wrong with that. But if you can let your supply of the frozen milk last you a little longer while you have enough milk that you can keep going with some fresh, that's probably the better way. But I have sent mothers home with enough milk that they could use it for 4, 5, 6 months. And it's certainly, there is absolutely nothing wrong with it. The only thing it's probably not going, it's going to be nutritious. It's going to have a lot of, it's got oligosaccharides in it. It's going to have the bacteria in it. It's going to be very good for your baby. The only thing is that your baby isn't going to get in real time from that milk what your baby would get in real time if you were pumping and you were providing your baby this constant influx of protection from infection.
Right. So I also want to touch on COVID, because you mentioned COVID. If mom is positive, the recommendations are to keep babies on the breast, or if mom has RSV or flu, any precautions that mom has to take when either breastfeeding on the breast, or if mom is pumping and she's positive, or in terms of hygiene or extra cautious, wear a mask. What are your recommendations?
You know, there again is a COVID education sheet for families on this Family Larson Rosenquist website. So that I think is a good place to begin. The recommendations I think would be the same as for anywhere. It's really good hand washing. And if you're home already with your baby and you're in a household I mean, what I have always taken issue with mask wearing and the strictness of separating and all, you can't do that in a household. And before you know it, trying to do that, your baby's going to be on formula. And there are so many data. We know, for example, we haven't really found that there is evidence that the actual virus is transmitted in the milk, but the antibody is transmitted in the milk. So we know the babies are getting the antibody. So at this point, I think strict hand washing, I would take care not to cough and breathe on the baby. But would I put a mask on? No. And I don't think there's good recommendations for that. You can't mask the 2-year-old that's going to come up and give your baby a kiss. So I just think, again, going through all of those things should have some tangible difference. If you're going to put all that effort into it, it should make a difference. And if you're in a big household and a small house, you're not going to be able to, your best thing is to exclusively breastfeed. I'll just offer, my own daughter-in-law with our first grandson is in the health department working on front lines with COVID when our grandson was born in January. And my recommendation to her was not a single drop of formula during that period of time, nothing but your breast milk. That way, if you're at risk, the best protection for the baby is exclusive breast milk. So that's from the mother or from the grandmother and mother-in-law to what I would advise in a COVID situation.
Thank you. That is such a very important message because there are so many unknowns, but this is one thing that we know, that what is best for the baby. Dr. Paula Meier, thank you so much for joining us here today. What a pleasure talking to you. We are going to make those links available to our community so we can share those amazing educational materials that we have created. So thank you.
Great. No, I'm excited. And anytime, I'm happy to come back. I love to talk to parents. It's my passion.
Thank you. I hope one day we can have you in person here in Canada. So thank you so much.
My pleasure. Thank you.
And for all of you watching us at home or in the hospital, thank you so much for joining us here today. And I want to again thank AbbVie and Pampers for the ongoing support to make this week possible for us. And CPBF is a registered charity, and 100% of all donations received during this week will go to our educational program for families. To donate, please go to CanadianPremies.org. It takes only 3 minutes of your time, but we make a huge difference in the lives of the families that we serve.